Welcome to Prescribed by Dr. Nathan Goodyear, where integrative oncology meets holistic healing. This podcast is your home for the latest in innovation, exploration, and elevation in all areas of integrative oncology, medicine, health, wellness, and beyond. Join me and a host of other innovators as we go from practicing to prescribing. Your daily dose of wellness begins now.
Architecture determines function. Recently, I had a conversation with a young patient. She said, "Gosh, do you think about cancer all the time?" And I thought, well, that's an interesting question. I guess I do. I guess Dr. Williams does as well. Now, we don't want to think about cancer, but because we see so many young people with cancer, equally so many older people with cancer, so many lives shortened by cancer, so many families affected by cancer, states, countries, etc. And so little is being done to really innovate in that space and change those numbers. Oh, sure, there's micro steps, but are we really seeing massive change? And with the changing demographics of cancer, we have to do that. The old line of thinking, the old way of thinking, the old way of acting need not apply. So here I am on a Saturday morning, been up since 5 reading studies, and it's about 7 a.m. and of course watch the sunrise. Beautiful. My wife would say I'm nuts, but I love to watch the sunrise. Nothing I love better because it's the start of a new day. It's the beginning of new opportunity. It's a crack in the door of possible where we can tackle something like cancer and take that impossible and make it possible. So I want to talk this morning in this podcast about architecture determining function. This is from a 2026 article, always trying to bring you up-to-date information, looking at spatial predictors of response of a particular type of metastatic colorectal cancer, what's called microsatellite stable, and these tumors' response to chemotherapy and immunotherapy. Check out the show notes for this episode, and you'll find the supporting studies there yourself. I encourage you to read them. Don't take my word for them. You know, we doctors say the craziest things, myself included. When you speak out, and I always encourage people when they speak out, whether that be in podcasts, on social media, or on the stage, because it takes great courage to do that. But sometimes your mouth and your brain, they're not exactly synced. That's why before I speak, I often pray. I always pray and say, look, connect my heart with your mind, my mind with my mouth, because that is important in getting that message across. So sometimes we say things that are just a little bit off and wrong. And if you speak and you hear people that speak on a regular basis, you hear that happen. And what you can't do is you can't dwell on that. You just have to move on. But I've been keeping track of things that patients tell me that are crazy that doctors say. Always thought it'd be a really good little book to have by in the living room or by the toilet. Crazy things that doctors say, number one, because these are so crazy that patients won't forget them. Your immune system is broken. That is crazy things doctors say. Number one, this podcast will specifically target that errored statement. See, the problem is when we look at metastatic colorectal cancer, this microsatellite stable, this is where immunotherapy and chemotherapy just doesn't work well. This constitutes about 85 to 95% of metastatic colorectal cancer cases. So the significant majority, I mean, we're talking up to 95%. And so in this, the chemotherapy and immunotherapy and combinations therein, they don't work. Now, for the past several decades, the standard for whether immunotherapy works or not has been based on biomarkers. And there's been great limitation of these biomarkers in terms of translation to clinical efficacy. But they've been the standard. It's kind of that standard of care. Okay, why was it standard? I don't know. It just has been. Does the research support it? Does the evidence support it? Or does the evidence support that the standard needs to change? And so I think that is a good framework of this discussion related to these biomarkers, because the biomarkers of PD-L1 expression, that's an immune checkpoint, tumor mutational burden, and microsatellite instability status are the standard bearers of tumor biomarkers for immunotherapy here, particularly related to colorectal cancer. But are they effective? Poor predictive value for PD-L1 expression. Tumor mutational burden is really insufficiently powered to discriminate against other matters or other markers. And the microsatellite instability, by definition, most of these patients are MSS. So it's so narrow. And so what happens is this limits the ability of most patients to get access to immunotherapy. Then why do we see immunotherapy work when you put it in the tumor when they're told that either their immune system is broken, crazy thing doctors say, number one, or they do these outdated biomarkers that fall short in predicting clinical efficacy? See, we're in a paradigm shift, and that's why we are super excited, not just in therapy, not just in thought, but also in assessment and biomarker. And the spatial biology and what it tells us about the tumor immune microenvironment structure outperforms these old, out-of-date biomarkers. So next time you go meet with your oncologist, say, hey, I'd like some up-to-date biomarkers, please. So let's understand the microsatellite status here as it relates to colorectal cancer, MSS versus MSI. So microsatellite stable, this is where we have normal DNA function repair. So what's happening here in cancer is there's a lot of ongoing replication. There's, as a part of that, there's a lot of damage done to DNA, and the ability to repair that is very, very important in reducing the mutational burden. And so when we look at MSS, microsatellite stable, what we're seeing is a lower replication error rate because of a more efficiently repair rate of the DNA that's damaged. And so you're seeing genetically stable profile. And again, this is normal DNA repair, low mutational burden, and this accounts for up to 95% of metastatic colorectal cancer. In contrast, microsatellite unstable high is about 15%, up to 15% if you go down to that 85% of MSS. And here, there's dysfunctional repair of DNA. So if there's damage because of the high replicative rate, the ability to repair that is lost. And so there's the accumulation, the acceleration of DNA replication errors, and it's a highly mutated genomic environment, landscape, if you will. And this, per standards, old standards, is what has been identified as efficient immunotherapy response. So that's just a little bit behind the scenes, behind what those old tumor markers that we need to move beyond say. So there was a recent study, as I mentioned, this 2026, looking at cell quantity to assess spatial organization and see if they're in unique link, not in link, do they work together? How does cell quantity, which has been the old standard, how does that translate to the new quality of spatial organization? And I would say that also applies to these tumor markers. This study was designed to actually identify spatial features of the tumor immune microenvironment. Again, the spatial omics area is so expanding, it's so exciting, the innovation accelerated by AI and the models that can be developed, it's really going to really revolutionize cancer care. But here they were saying, okay, where are the cells? What and how are they organized? So what cells are there? Where are they? How are they organized? And is there meaningful, obviously immune activation, immune-tumor interactions? See, the traditional view has been that it's about the immune cell count. Now, there's some degree of truth to that. If somebody's lymphopenic, they're low in their lymphocyte count, and they're on chemotherapy or immunotherapy, their outcomes are going to be worse. So you've got to elevate those lymphocytes. But the new paradigm is not, it doesn't eliminate count, but it's saying there's so much more that actually is more important. You got to map the spatial structure and arrangement of the immune cells. The clinical goal here is to identify patients that respond to immunotherapy better. Honestly, the clinical goal here is to reprogram the tumor immune microenvironment to allow the immune system to actually target, and destroy the tumor itself. Empower the immune system and let it do the hard work. Let it do the dirty work. Because the immune system, more often than chemotherapy, radiation, immunotherapy, It's going to be able to target the tumor and not your healthy cells. And of course, the immune system can be there. So in this study, what they did, and this was human study, they took sample collections from patients that were, again, microsatellite stable, metastatic colorectal cancer. They took tumor samples, and they did high-dimensional profiling via two techniques. They did multiplex immunofluorescence imaging and then spatial transcriptomics. I talk about that multi-omics. I talk about genomics, epigenomics, transcriptomics. Transcriptomics is that field of study of looking at DNA going through transcription to RNA. And then they did spatial analysis and mapping the immune cell distribution and the architecture. And then they looked at responders versus non-responders. And they classified, very importantly, in these responders versus non-responders, radiographic and clinical criteria. See, a lot of people on social media, they're presenting articles of patients' testimonials as it relates to nutraceuticals, nutrition, repurposed medications, and I use all those. We use all of those with great precision. However, they say, well, we're cured. Okay, what's the radiographic and what's the clinical criteria to determine that? Because somebody just saying I'm cured, does that really mean that? And cure is not even a scientifically validated term. And this was my whole beef with that study that came out. It was just basically an observational cohort looking at ivermectin and mebendazole. Though I celebrated that, and we use those meds when indicated as repurposed adjuncts as it relates to cancer. But there was really no clear identifier radiographically or clinically of what was, quote unquote, a response. And they also looked here at spatial distribution of CD8 T cells, myeloid cells, such as tumor-associated macrophages and myeloid-derived suppressing cells, tumor cells, and stromal components, the architecture of the stroma. And they looked at cell-to-cell proximity and the immune niches, and they mapped these in the tumor immune microenvironment. What they found was very interesting. The spatial proximity of immune cells to each other and to the tumor outperformed immune cell quantity. Let me restate that, because this is a paradigm shift. Spatial proximity of immune cells and the immune cells to tumors outperforms the quantity of the immune cells. See, the key observation here was that the treatment response was strongly associated with the close physical structural proximity, organization of the CD8 cytotoxic T cells to the tumor cells. Not merely the numbers. In fact, high intratumoral T cell density was an unreliable predictor of response, blowing the number, it's about the number, out of the water. And I mean, this goes back to know your number as it relates to testosterone. Come on. Now, is it important to know the lymphocytes and raise them? Yes. But what this is saying, this study is showing, and other studies have shown this as well, is when you want to engage the immune system, which should be the goal for every doctor treating cancer, it's about space and relationship, spatial relationship. The implication here is that effective anti-tumor immune activation requires direct immune-tumor cell interaction. T cell receptor engagement, activation, cytotoxic granular release, and interferon gamma release. See, this is the process of seeing tumor infiltration of immune system, engagement, activation, and training, and then active anti-tumor immune competence. And guess what? You can look in the periphery to see this evidence, but most don't. So the core principle here is that spatial accessibility is the rate-limiting aspect of immune activation, not tumor mutational burden, not MSI, MSS, not PD-L1. Immune-excluded architecture drives the resistance. 50 to 75% of tumor immune microenvironment per research as of today suggests that 50 to 75% of them are immune-excluded. And in the non-responders, that's what they saw here as well. What they found is that the CD8 cytotoxic T cells, again, in this immune-excluded, what happens, immune cells are recruited, but they're kept out. And so what they found here in the non-responders is that the CD8 cytotoxic T cells, they were confined to the stroma and peristromal tissue of the tumor. They're not in the parenchyma. So they're not in that ability to engage directly with the tumors. Here, this is an immune-excluded phenotype. The immune system can't be engaged. So the structural basis here is that the tumor does many things to keep the immune system out. It's not that the immune system is broken. In fact, when you look at most patients with lymphopenia, it's because they've had chemotherapy and radiation before, and even systemic immunotherapy. So if they want to use that argument, it's because they broke it in a way. Bone marrow suppression, they broke it. So they broke it, and now they expect somebody else to fix it. We have to recognize that the immune system's not broken unless it is unintentionally or intentionally, depending on how you look at it. But it's actually that the tumor creates many different barriers. It creates immunologic barriers. It creates stromal barriers, very fibrotic with cancer-associated fibroblasts that the immune system can't get in, acid-base barriers, interstitial pressure barriers, many different barriers that simply keep the immune system out. And here in these non-responders, that's exactly what was seen. And so here, chemotherapy, immunotherapy fails because of the architecture, the organization, the barrier, the rebuffing. So what has to happen is you have to restructure that. You have to reorganize that. You have to reprogram. One of the biggest barriers that plays a role in immune evasion is the tumor's ability to recruit immune cells to its environment. But then it uses these, particularly here, myeloid cells, to create an immune suppressive barrier. You know, it's almost autoimmune-esque, and I'll talk really briefly about a study that just came out. But so the tumor recruits the immune system to it and then uses those immune cells to rebuff the immune cells, CD8 cytotoxic T cells. See, in the non-responders, there was significant enrichment, high levels of these myeloid-derived suppressing cells. What are tumor-associated macrophages? Here would be the macrophage type 2, which, by the way, a lot of the M1 subtypes are recruited into that tumor microenvironment, but the hypoxia, the environment within that context of the tumor microenvironment, shifts the polarization of the M1 to M2, which is immunosuppressive. And then myeloid-derived suppressing cells, which are outright immunosuppressive, also T-regulating cells. So, but what's interesting is the tumor-associated macrophages and myeloid-derived suppressing cells also create physical barriers, a cellular wall, if you will, and biochemical exclusion. So there's a production of many different signaling agents, interleukin-10, which, by the way, you can monitor, transforming growth factor beta, which, by the way, you can monitor, but most don't, endolamine 2,3 dioxygenase, which you can monitor that pathway, and most don't, and arginase 1. These are chemical markers that you can, signals that you can follow that tell you whether we're dealing with an immune-excluded, biochemical excluded barrier in and around the tumor. Because with that, what happens, this suppresses T cell recruitment, proliferation, activation, and maturation. Suppresses the immune system. And this has predictive significance as it relates to the myeloid cell and the density within that tumor microenvironment and the localization about whether this is going to be an immune-engaged environment or an immune-excluded environment. In fact, this is the strongest spatial correlation for treatment resistance. Not PD-L1, not tumor mutational burden, and not MSI. Now, I just mentioned there was a study that just came out, CD300LD on pathologically activated neutrophils promotes tumor immune suppression by binding phosphatidylserine on CD8 T cells. Great Saturday morning reading, Corey, or great nighttime reading if you have insomnia. But what's interesting here is they found that pathologically activated myeloid-derived suppressing cells, they were recruited to the immune environment. And what this then was a primary immune evasion technique to suppress CD8 T cell, promote CD8 T cell tolerance, so the CD8 T cells couldn't be effective. So again, here's the evidence of very specific polymorphonuclear myeloid-derived suppressing cells being recruited and actually through very specific activation, creating tolerance by suppressing CD8 T cell activity. Crazy. The immune system being used against the immune system. They also looked at immune tumor niches in the tumor immune microenvironment to assess the phenotype. See, the goal here is to actually say, how do we do better? And in immune tumor niches, in the responders, what they found is organized, not chaos. Cancer creates chaos. Organized regions of immune cell to tumor co-localization. Very structured niches containing CD8 cytotoxic T cells, antigen presenting cells, tumor cells, all in close spatial proximity to each other. I've talked about the 2024 study talking about the triads being predictive of response. that is CD4 cells, CD8 cells, and actually antigen-presenting cells in close proximity and in relationship with tumor tertiary lymphoid structures. See, the architecture here in the responders was one of functional immune communication. And with standard of care as it relates to most cancer treatment, at least the way they look at whether immunotherapy, chemotherapy could be a responder, could be a response treatment in MSS, metastatic colorectal cancer, that's flawed. But also the treatments themselves, chemotherapy, systemic immunotherapy, radiation, etc., could also be promoting the disorganization within that. But it's the organization of that structure that really determines the response, and also the formation and the maturity of the tertiary lymphoid structures, which are the forward training immune camps that allow the immune system to be trained and activated. And it's the spatial tumor immune microenvironment phenotypes. And I've talked about these repeatedly because we must change the way we think. Is this environment inflamed? Is this environment immune-excluded? Is this environment immune desert? And I'm going to talk about a study in the next podcast where looking at circulating fragment DNA and how we've looked at that all wrong, looking at tumor burden and residual disease and genomic sequencing, we can actually use that to guide us on what's going on inside the tumor immune microenvironments and determine what's there to better determine how to engage the immune system. But here in the study, in the responders versus the non-responders, the spatial omics, the spatial profiling outperformed the traditional biomarkers. Now, what does that say? We need to bring the concept of this spatial omics, spatial profiling to clinical practice quickly because the traditional biomarkers don't work. They don't work well. Now, let's talk a little bit about chemotherapy. And obviously, you know how I feel about chemotherapy. I think it's one of the unholy trinities. But obviously, sometimes we need to reduce tumor mutational burden. Just if somebody walks outside, breaks a hip, I'm not going to tell you just take more vitamin D. You need to surgically repair that. So sometimes we need full-dose chemotherapy to reduce tumor burden. But I think in many cases, a lower dose and metronomically delivered dosing of chemotherapy is more impactful. Chemotherapy can have immunogenic contribution, and in the study they talked about it, but here they're talking more about full dose. They talk about immunomodulation, but I would tell you that immunomodulation is more applied to low-dose chemo than it is full-dose chemo. But high-dose chemo has been shown to increase antigen production. Of course, it's going to kill rapidly dividing cells. The problem is it does that to immune cells. It can enhance T-cell recruitment because of that antigenic production, and it can transiently reduce the myeloid-derived suppressing cells. Now, this can happen at standard full-dose chemo. However, when you want to look at the process of immunomodulation, suppressing the immune barriers and actually elevating CD8 cytotoxic T cells, natural killer cells, and even their maturation and activity, that's where low-dose metronomic chemo is shown to come in. So low-dose metronomic chemo, which is somewhere between 20 and 30% of the full-dose chemo, it's not directly cytotoxic, though it can have a little bit of effect of that. It's primarily anti-angiogenic. That's where it was developed. But also here it's immunomodulatory. So if you want to engage the immune system, actually it's going to be better to do a low dose metronomically than for full dose if you want to reprogram. But when you look at chemotherapy, it's insufficient. It alone cannot overcome the barrier that's keeping the immune system engagement out. And it's because of the myeloid suppression that it does not reprogram, the stromal exclusion barrier that it does not break up. And so the recruited T cells still cannot access the parenchyma of the tumor. They cannot access the mature tertiary lymphoid structures because the architecture has not been remodeled enough. The critical gap of knowledge here, and this is where there's the resistance to change, but where the science says there must be change, is that chemotherapy and systemic immunotherapy combinations here, I'm talking about the conventional approach, they fail to address what is now known and becoming incredibly well known, the structural architecture and organization that's required for immune engagement to counter immune desert and immune-excluded environments and engage them to be inflamed, actually transform them to be inflamed through engagement of the immune system, actually getting to the root cause of why resistance develops. See, resistance, it's a failure, not of the drug, but of the spatial organization. It's not immune absence. It's more than simply a quantitative value. Oh, it's simple. What's the number? But that's not the reality. That's not the science. It's spatial organization. It's immune cell presence. Of course, there must be some numbers. And if you've had a lot of chemo, a lot of systemic immunotherapy, radiation, etc., it can compromise the numbers. And there can be things to do to increase those. Interleukin 10, of course, interleukin 15, Dr. Soon and Activa, great process to do that. Even thymosin alpha 1 in conjunction with melatonin. Lower doses, significantly lower doses of interleukin 2. All of these can be ways to increase the T cell presence. But you must also have proper localization, not just at the tumor. They must be in the parenchyma of the tumor, and they must be in close proximity to the tumor. There must be structure, and there must be interaction. This must be organized. And see, this is why I think chemotherapy eventually accelerates cancers, because it creates disorganization. Where have you ever seen war bring organization, bring structure? Of course, if you defeat the enemy, then that will come. But all war does is it creates chaos. It creates disorder, disorganization. It destroys infrastructure. But proper immune engagement requires infrastructure, structure, organized interaction. And that then enables sustained engagement. And it, in the process, also maturation of those forward training camps, tertiary lymphoid structures that then are in proximity to the parenchyma, that then allow that immune engagement with that triad of immune cells. So again, the immune cells are in proximity to each other, in the proximity of the tumor, and they're all spatially related in close contact for that engagement, for that immune activation. See, the entire structure of cancer care up to this point has not been to engage the immune system. Now, that was not the no, but it destroys that structure. Here in this study, the clinical implications are profound. The spatial profiling redefines therapeutic strategy. Imagine that you go to your doctor, you're diagnosed with cancer, and they said, we're gonna spatially profile the tumor. And that's going to determine how we therapeutically strategize to reprogram it. The future of cancer care is reprogramming. That's why this is so exciting. No longer do we have to destroy your body, hope you survive, then recover, then heal, then live. The capacity to live as you heal is very real, but it's through this new spatial omic strategy. And we must do it at the baseline, in the beginning. And at the Williams Cancer Institute, we do that right now. We've been doing it for years. We target the tumor immune microenvironment, whether it's immune desert, immune-excluded, or inflamed, and there's techniques and ways that you can tell that, to actually reprogram. We can specifically, if there's myeloid, if there's evidence of a immune suppression, particularly here with immune-excluded, which dominates, and there's myeloid cells, we can come in with therapeutics, inject it into the tumor. We break through the barrier, go right into the tumor. Are you there? Yes. How do you know? We see it. The needle's in there. The therapy's injected into it. Well, is that going to counter that immune suppression? Yes, because we put the drug there. We don't have to worry about the rebuffing of it. Well, what about antigen exposure? We ablate the tumor within the tumor. We can remodel the stroma. How do you know that? Because we put a needle in there and we ablate it. Of course, we love the biphasic pulse electric field therapy because that creates the best immunogenic cell death. And here, stromal remodeling, and it opens the doors to the immune system coming in. But it does it through remodeling, rescaffolding that fibrous, in many ways, structure tumor microenvironment built by the cancer-associated fibroblasts. And this is all going to enhance T-cell trafficking into that space, into that organization, into those feed-forward training camps of tertiary lymphoid structures in proximity to the tumor parenchyma of the tumor cell to engage the immune system. And when you engage the immune system, it recruits other immune cells to come to it to destroy the tumor, not you, but then it sends cells out and it maintains memory. Where does chemotherapy have memory? Where does systemic immunotherapy have memory? Where does radiation have memory? Oh, there's memory, all right. There's memory of the damage, the side effects. But what if we instead said, let's get memory of the immune cells? It's turning the tumor into the source of a vaccine, not outside, but inside. It's taking your immune cells, inoculating the tumor, inoculating the immune cells to the tumor, inside the tumor, and turning it into the source of a vaccine. Now, of course, people say, oh, vaccine, polarization. Again, I say this all the time, that which pertains to a cow, that's what it means. So it's inoculation, that's the key. So how do we turn immune-excluded to inflamed tumors where immune system actually is engaged? Intratumoral ablation, intratumoral immunotherapy, spatial omics, precise delivery of therapeutics that are designed based on the type of tumor immune microenvironment to reprogram, to restructure, to reorganize, to enable the immune system to gain access to develop tertiary lymphoid structures, which, by the way, PEF has been shown to do, mature them, put them in proximity to the parenchyma of the tumor, the most hypoxic areas, and let that spatial organization do what this study showed that it does in responders versus non-responders. It's the ablation, it's the intratumoral immunotherapy, it's the conversion strategy, the transformation strategy, the reprogramming. See, what this study has shown in others is that it's location that's over relationships, that's over quantity. So location is more important, relationship is more important than quantity. It's the spatial architecture of the tumor immune microenvironment more than the immune cell numbers. The T cells in the stroma is not the T cell in the tumor. Structure, organization is function. Again, that's why when you look at chemotherapy, surgery, and radiation, they don't create structure. They create disstructure, disorganization. Now, there can be a moment and a time and a place where you need that, where the risks and the benefits have to be evaluated. Tumor burden, reducing that. Vital organ function threatened, brain metastasis, but structure is function. We have to reprogram the architecture within the tumor microenvironment, particularly the tumor immune microenvironment, through mechanical disruption here with PEF ablation, cryoablation as well, histotripsy, but you got to couple that with immunotherapy. You cannot just use ablation as an alternative to surgery or regional radiation. You cannot do that. You will not engage the immune system appropriately. But mechanical disruption, ablation, plus immune activation will overcome the exclusion, spatial, bringing the players together to convert to an inflamed phenotype where the immune system can actually engage the tumor. Now, even within an inflamed phenotype, there's still the process of what's called restraint, inhibition. It's still not optimally functional, so you have to steer that. So that's the future. But it's not something you have to go, I can't wait to hear about that. I can't wait to see when that comes to clinical practice. I'm happy to say it's here. It's available. At the Williams Cancer Institute, we're bringing the future of cancer care to you today, and it's all evidence-based. So then the question is, well, why is conventional oncology not embracing this? Well, you have to understand the thought process, the thinking, it's ingrained. There's a lot of pressures to keep a form of thinking, to keep a strategy of thinking. A lot of money too, but it's about the patients. It's about serving the interest of the patient. And so that's why I say the future is integrative oncology, because it's simply following the science. It's not bound by the belief of science. Actually, the understanding is discovered through the science, and that leads the way for innovation. We equally need innovation in the regulatory process to approve that, of course. That includes the right to treat, the right to try. The right to try applies to the patient. Right to treat, that needs to be empowered to and govern protection for the doctor, because the patient, we can pass right to try laws in the United States, as Trump has done, but if there's no right to treat protection for the physician, the hospitals won't allow it, insurance doesn't reimburse it, nothing. Nothing's going to happen. Nothing's going to happen. This is the future. It's not about numbers. It's about spatial relationship. And it's not about the biomarkers of PD-L1, MSS versus MSI, or tumor mutational burden. It's about structure, organization, and relationship of the immune cells. The right location, the right time. That's why I say precision medicine, precision oncology is the right treatment for the right patient, in the right combination, in the right space, in the right locale, at the right time. Spatial omics. So we really need your help. We don't do ad buys. Everything we do is organic. Everything. I believe in real relationships. I don't believe in bots. Yeah, bots can sometimes find you, but I believe in real relationships. I want to hear from you. I want to hear your questions. What do you want me to talk about? What do you want to know? What do you want to hear? What do you want to learn? So with that, we need you to subscribe to the podcast and share this for others to subscribe to the podcast. Like the podcast, drop us a 5-star review. Drop us your question. And as always, as I said, share it with those that you would think would benefit from it. Yeah, send it to politicians. Send it to scientists. Send it to doctors. They are scientists too. That's the way we grow more doctors. We build bridges through the science. That's how we help more patients. But you as patients, you're the force vector of change. That's power. But that power is fueled with knowledge. So please take this and spread it. Empower yourself and empower your future in cancer treatment. Not in number, not in outdated biomarkers, but in immune spatial relationships. I'm Dr. Nathan Goodyear, and this is the Prescribed by Dr. Nathan Goodyear podcast, and I'll see you on the next podcast.
Thanks for joining us on this episode of the Prescribed Podcast. All references supporting this episode can be found on the prescribed.com website. That's pre-scribe.com. To get your next dose of medical innovation, make sure you subscribe to Prescribe. We'll see you for your next refill.